Good afternoon, everyone, and thank you for joining us for our first installment in a new webinar series exploring Kentucky's urban and rural divide, organized by the Kentucky Chamber of Commerce and the Martin School of Public Policy and Administration at the University of Kentucky. My name is Charles All. I am Senior Policy Analyst at the Kentucky Chamber, and I have the pleasure of moderating our discussion today, and we're really excited to get that going and get into a good conversation here. In Kentucky, it's often said that the thing that divides us the most is not politics, it's not partisanship, it's not class, it's not even UK versus U of L. Rather, it is the urban-rural divide. And at the core, this is the thing that really sort of separates Kentuckians and dictates a lot of public policy and decision-making. And so the goal of this new webinar series is to bring together policymakers in Frankfurt and experts from the Martin School to engage in thoughtful discussions about the realities of Kentucky's urban-rural divide and explore ways to bridge this divide, because ultimately that's how we're going to figure out how to do that. It's through these conversations and through very honest conversations. And so the conversation today that we're going to be having is going to focus specifically on the urban-rural divide in the context of healthcare. Future conversations that will take place later this summer will deal with issues such as economic development and education, but today we're going to be focused particularly on healthcare in the context of the urban-rural divide. We have a really great panel that's going to help us do that today. Some really top-notch experts in the healthcare field with experiences in urban and rural communities throughout the Commonwealth, and I'm going to introduce them really quick before we jump into our conversation. We have Senator Ralph Alvarado, who represents Clark and Montgomery counties, as well as part of Fayette County in the Kentucky State Senate. And he serves as the chair of the Kentucky Senate Health and Welfare Committee. We have Representative Kim Moser, who represents parts of Campbell and Kenton counties in the Kentucky House of Representatives and serves as the chair of the Kentucky House Health and Family Services Committee. We have Mark Birdwhistle, the Vice President for Health System Administration and Chief of Staff for the University of Kentucky Healthcare. And I should point out he is a graduate of the Martin School. And then we have Larry Gray, who is the president of Baptist Health Louisville and the former president of Baptist Health Corbin. Mr. Gray holds a bachelor's degree from the University of Kentucky. He is also a Martin School alum as well. So thank you all for being here. Thank you for your time and your willingness to have this conversation with us. And we're excited to jump into things. I want to make a quick note to our audience. We're going to wrap up at 1 p.m. Eastern time. So just sit back, enjoy your lunch. You don't need to rush or anything like that. If you have questions for our panelists, please write them out as clearly and concisely as you can in the chat. And as time permits and as topics permit, we'll do our best to get to those questions. On a similar note, I want to request that our panelists try to keep their responses as brief as we can so that we can cover as much ground as possible. So with that, I want to jump into things. And I think with any good conversation, it's always good to establish some sort of foundation and to build out some context. So what do we mean by things like the urban-rural divide in the context of healthcare? What type of disparities do we see between urban and rural communities? How are the healthcare needs of urban Kentuckians different from rural Kentuckians? So instead of me reciting a bunch of facts and data on that issue, what I want to do is go to each of our panelists and ask you to point to a particular statistic, data point, anecdote, story, challenge, whatever you want, but whatever you can think of that you think aptly illustrates Kentucky's urban-rural divide in the context of health and healthcare. And so, Larry, I'm going to start with you, and then we'll go to Representative Moser, followed by Mark and Senator Alvarado. So, Larry, let's start with you.
Okay, thank you, Charles. You know, I was looking at some national data, and it struck me again that just, for example, on some of this data, when you look at what they refer to as excess deaths for leading causes of death, heart disease for rural communities was 42.6% over what you would have normally have expected, whereas in metro counties it was 27.6. That is a huge marker, a signpost. And you can go through most disease processes and disease states and see the same kind of data. When I was down in Corbin as president, I would have assumed that that's rather ubiquitous across all of rural Kentucky. and is part of the divide between rural and urban. However, now being in an urban market, what I'm also aware of, when you start teasing that data out, the congregated or aggregated data for an urban market hides the fact that across zip codes, there is actually sometimes even a greater divide from zip code to zip code on some of those statistics, as well as some of the services provided. So it reveals a lot of issues that I hope that we can begin to really work towards and uncover together.
Thanks, Larry. Representative Moser.
Yeah, thank you. Thanks for having me this morning. It's a real pleasure to be on here with you, and I'm really, obviously heavier on the policy side. So, but in looking at some of the data, and I appreciate very much what Mr. Gray said, because it's true. We do see these very poor health metrics, and largely coming out of the rural setting. But it was interesting when I was looking at some studies. Rural communities face higher unemployment and higher poverty levels and suffer from a lack of resources. So some of this might help explain some of the higher rates of these poor health metrics, or higher rates of substance use disorders, things like that. According to the Office of Disease Prevention and Health Promotion, actually 89% of people under 65 years of age in the US had health insurance. And so that was in 2018. I don't know if it's ticked up. Certainly, in Kentucky, we've seen a heightened use of Medicaid, especially during COVID. But it was interesting to note that coverage by ethnicity and things like that are maybe what you would expect, but they weren't as disparate as I thought. So Asians had the highest rate of coverage, and Caucasian, so that was like 92.6%, Caucasians 92.2%, not very different. And then moving down, Blacks or African Americans were at 87.9%. And then the lowest was actually Alaskan Natives at 71.4%. So, some of these metrics, I was a little bit surprised. I was a little bit heartened to see that the rate of health insurance has actually increased. And I was looking again at some of these studies. A 2018 Robert Wood Johnson study revealed that the cost of health insurance is actually higher in rural areas, primarily for a lack of competition in the market. And that's opposed to urban areas. So factors like market competition and certainly policies that we need to be keenly aware of, and the unintended consequences of some of the policies that are put in place are a factor in some of the healthcare, such as the ACA premium tax credits that actually lead to different premiums for insurers in rural versus urban areas. And so I know we're going to get into more details, but those were some interesting points that I kind of found.
And Mark?
Well, it's going to look like we've rehearsed this, and we actually have not rehearsed this, but it does kind of feed off of each other. One of the things too, and I think the latest buzzword is social determinants of health. And I think Larry would agree that, we were talking about housing, transportation, education, how all of those factors feed into how people access healthcare services, how and when. And I think we're learning now that coverage is broader than it used to be, that many of these social issues are more pronounced in the rural areas. The only statistic I've garnered recently is the education statistic, and it's some of the data is showing from the U.S. Department of Agriculture that it's almost twice as likely for somebody in the urban area to complete a high school or college level of education as their rural counterparts. That gets you into the healthcare literacy side. I think those of us in the healthcare world try to create our own language. and it's not intuitive. The term deductible, that's hard to explain in English. I've been doing this 45 years. I still have to dissect it every time. So I think education, literacy, healthcare literacy, and social factors such as transportation are key contributors to that divide.
Senator Alvarado.
Yeah, first of all, thank you all for having me on here. It's a distinguished panel. Obviously, Chairwoman Moser and I get to do a lot of these together, which is always fun. We've been friends a long time. You get Larry Gray and Mark Birdwhistle, great guys, they're well known. I also see the people on the participants list. I got to throw a shout out to Dr. Steltenkamp, who helped train me in pediatrics. So to see that name is always fun to see, and a lot of familiar names on that list as well. You're looking for some anecdotes on things between rural and urban divide. I mean, obviously substance use disorder, like Chairman Moser mentioned, is one thing. Our tobacco rates is famously in Kentucky. We know we have a lot heavier tobacco use in a lot of our rural areas, although that's heavy across the board. And I think, as Larry mentioned, a lot of our heart disease rates, the cardiac valley that we talked about really for Kentucky, and the fame nationally of that, of the amount of heart disease we have in portions of the state that's related to tobacco use. I think other things that we're looking at, obviously, our obesity rates are much higher. We know during COVID-19, a big risk, and the higher obesity rates tend to have more hospitalization rates, more negative outcomes with COVID. As we are more rural, people depend more on driving to places or not going places. There's more of a sedentary lifestyle as a result of that, because you have to drive to get to locations. While you're in urban settings, you may walk more, bike more, do some of those things. So that does play a factor. I think also we talk about telehealth. Broadband access leads to a lot of access to care for people to be able to get treatment. Areas that have better access for that will probably, especially during, again, a COVID pandemic when things were heightened a bit more, you can get to be seen more easily, although we do have areas that are difficult in urban settings for that as well. So all of those are important. I think there are some good news. I mean, there is one statistic. We know that the Colon Cancer Foundation has done a lot of work. Kentucky's colon cancer rates were particularly bad. I think our colon cancer death rate was #1 in the country. It's not something you want to be top dog in. We have a lot of colon cancer in our state. So we started making an effort to try to do better at screenings. And I think from a screening perspective, Kentucky was ranked 47th, I think is what it was about 10 years ago. The Colon Cancer Foundation came in, put forth a massive statewide effort in education, both for providers and trying to get, really patients to get their colon cancer screenings done. We passed some bills that would recognize a lot of the national standards to make sure that our insurance companies were covering those things. We've gone from 47th, I think, to 19th in colon cancer screenings in Kentucky and on a national scale, which is tremendous. That's going to rub off on our death rates probably in the near future when we look at that in about 10 years. We know that in Western Kentucky, our colon cancer screening rates are well over 80%. In Eastern Kentucky, we're still in the 50s, mid to upper 50s, which is still, we have some work to do there. But we're well above our goals in Western Kentucky and the center parts of the state. So there are some rural portions where it's responded well. There are some rural portions where we still need some work to be done. So a lot of that is there. And I think a lot of it also follows really our socioeconomic, and I'm sure we'll get into that a little bit too, is, job opportunities. If you have the opportunity for work, different kinds of insurance coverage, people will have better access to care. And we know that our rural parts of our state, with the decimation of the coal industry and other things, have really taken a massive hit, population loss. That all plays a factor for Kentucky moving forward. So it's such a huge topic, so many tendrils and factors in that, but there is some hope because we've had some things that have actually worked well in our state here.
So there's obviously a lot of different ground we could cover here. Two major topics I want to get into that I think will have multiple spurs as we talk through them. One is going to be insurance, healthcare coverage, and then from there we'll go to healthcare access and kind of separate those out for a minute. Let's start with the coverage issue. As I was doing some research on this, and Representative Moser has already kind of alluded to this already, but as I was doing research, I came across a few different data points illustrating disparities between uninsured rates between urban and rural communities. Census Bureau, for example, points to about a 1 point difference. And as Representative Moser has already pointed out, we've made really big gains as a state as a whole, but that disparity does still seem to exist between our urban communities and our rural communities when it comes to healthcare coverage. So I want to start with Mark and Larry and have you two try to help us understand why is there a disparity between the uninsured rates between urban and rural Kentuckians? And why is it significant or not significant? And then from there, we'll go to Representative Moser and Senator Alvarado to get more of a policy perspective on that.
So Larry, you want to go first?
Sure, I'll jump in. I think has already been pointed out as well that some of the concerns are the kind of isolation, the job access, and the probably a much lower amount of employer supplied insurance. But also when you start looking at the fact that so many people are either self-employed or small business or agricultural concerns in the rural markets, and especially in the eastern part of our state, where there are larger swaths of population where there is not a major town center and resources. I think the whole issue of isolation and getting people to a place and the help they need to sign up for insurance is an issue that we face. And well, I'll stop with that. Let Mark jump in. I have some suggestions for that. But
Yeah, I think we all could. So I think Larry's right. Many of the small employers struggle to be able to provide employer-sponsored health insurance. You find the smaller employers in more of the rural areas. And I think affordability becomes an issue. Where can they find affordable coverage? And when you get the affordable coverage, what is the out-of-pocket requirement, the premiums, the co-insurance, the deductibles of that plan? Which leads me to kind of my life's work in the Medicaid space. I think Medicaid, when I began in the program in the late 70s, it was a program for moms and children who were very low income. I think it has evolved to the main stage. It's something I never thought I would see. But Medicaid has filled that void. So I would contend that a lot of people, I know, Charles, you don't want to talk about access yet, but I'm going to push it, that, just because you got coverage does not guarantee you have access.
yes,
And that, I think that's a misnomer. When you look at those maps and you see all of the counties with certain percentage of the populations covered, a lot of that is Medicaid coverage. Many providers don't take Medicaid. And so that doesn't necessarily translate that those people in those counties have access. So I think it's twofold. It's the safety net program of Medicaid may be kind of leading people to feel like they have coverage when they may not have access. Those that have commercial coverage, there may be gaps within that because of the co-insurance, the deductibles, and being able to work within that system.
I would say, Mark, in addition to that, and Representative Moser brought it up earlier about the higher cost of healthcare, but part of that issue from the research that I've been involved in is not just a pricing issue, but the actual out-of-pocket cost for the individual is higher in the rural markets. And some of that, I believe, is because of the kinds of policies that are being marketed there and what can be afforded by small businesses, as well as what can be bought into on the exchanges. I think, and I agree with you wholeheartedly. What I saw in my work in Corbin was the increased amount of patients who had coverage but who could not afford their copays and their deductibles. And we will, I think, continue to see that.
So let's bring public policy into this conversation about coverage, and then we'll shift to access after that. Senator Alvarado, Representative Moser, what is the role of policymakers in reducing uninsured rates in urban areas and rural areas? What's been done in the past? What remains to be done? We'll just kind of go from there.
Do you want me to go first?
Sure.
Okay. So And I love the conversation with Larry and Mark earlier about, and it seems that one of the recurrent themes in all of this is employment. And I think that, you know, as we talk about this, that keeps rising to the top. So obviously improving our economic standing in any of the rural areas is going to have a positive trickle down effect. I would agree with something that Larry said earlier in talking about health literacy. I think that oftentimes people just need accurate information and a connection to resources. It seems that we are building resources, and you know, the more conversations I have, it seems that one of the barriers is connecting to those resources. So you know, I think that there are some policy decisions that I've had conversations with individuals about. One of those is the issue of certified community health workers and whether or not they are covered by Medicaid or reimbursed by Medicaid to really address and bridge a gap in assessing individual needs, especially if they're embedded in primary care offices and connecting people to the resources and the healthcare that they need. Especially, you know, we do talk a lot about socioeconomic health disparities and the way that it affects healthcare. So that is one policy that we're looking at possibly expanding, having conversations with the cabinet. We already have peer support specialists who are in that space specific to addiction issues. Telehealth is a policy decision that was made and passed several years ago by Senator Alvarado, and we updated that this past session to really keep that front and center as a connection and access, improving access to care, kind of no matter where you are. And so, you know, it addresses the transportation issues, for example. And another policy issue that I have talked about, and I really should just defer to Mark Birdwhistle on this one because he's much more of a Medicaid expert, but these are conversations that we've had. And Charles, I think that you were part of this before you moved over to the Kentucky Chamber. We were talking about bridge insurance and what that possibly looks like, and how we address things like short-term health plans, really analyzing the cost effectiveness of those plans versus the same coverage through Medicaid, maybe involving public-private partnerships to, you know, get creative with the use of things like TANF funds, unobligated TANF funds to, you know, kind of roll it through an employer. It would create a system where it would incentivize folks to get back to work, and the employers would have some subsidized help from the state and some skin in the game to provide benefits to individuals. And it would also help address the benefit cliff, which we hear a lot about as really, in my opinion, a disincentive for keeping people, or a perverse incentive for keeping people kind of looped into the system, which is never, should really never be the goal. So I think that there are some policy issues that we can really hone in on.
Yeah, so to tie into that, Charles, really, we talk about trying to help, what can we do as far as policy to help reduce, you know, improve coverage and do those sorts of things. There's a philosophical debate that typically occurs within any state legislature or Congress as to how much government should dictate that. So when we talk about, hey, if I want to buy a policy that's short term, or I want to buy a type of policy that provides me only limited coverage, the government stepping in saying, you know, you have to have a certain kind of coverage. We think we know the kind of coverage that you should have. That becomes a big philosophical debate as to how much should the government step in and dictate the kind of insurance you want to buy for something in particular. Now, we do that with things that, you know, if you buy a car, you have to have you have at least minimal types of coverage with that. But healthcare coverage is something that, you know, just by existing, that you're having to buy that. And that becomes the big debate. We heard it with the rollout of the ACA and Obamacare, is how much government needs to step into that role. So that's always a big debate, a big policy discussion. Nothing's been decided on that yet. I think we're having discussions on those things. I think one of the good things we did see roll out was a federal program more than a state one, was the association health plans, which I know Senator Rand Paul pushed President Trump kind of got advanced, which was a welcome relief for a lot of our business community. And people were able to buy, again, affordable, people were able to team up that had similar interests and buy policies to help reduce those costs. Really helped out a lot of small businesses. So when I had people locally saying, hey, look, I'm a small mom and pop, I got, less than 5 employees, what can I do? These association health plans were a lifeline for a lot of those people to buy private insurance, get it that's affordable, to team up with others that had similar interests. I think one thing you got to talk about, healthcare transparency becomes a huge issue when it comes to costs. People don't know what they're paying for. Healthcare is very confusing. A lot of times individuals will try to shop for something online. You can shop for a pair of shoes and price shop and compare. Good luck in doing that for an MRI. If you need an MRI of your knee and you're getting it through State Farm through a car wreck, you'll be paying $3,000 for that. If you're getting it through Aetna because you might need a meniscal tear, it's $1,200. If you're self-pay, it's $500. So what's the cost of that MRI? I couldn't tell you because it depends on who's paying it and what the situation is surrounding it, which it shouldn't be that way when it comes to that. I've been advancing a bill for healthcare transparency. I think the feds just passed a surprise billing bill that included a lot of health transparency issues. I got to review that bill in more detail. I think there's more in that bill than we realized as to what we're going to start doing and start, having a little bit more openness. That would really benefit, again, a lot of our small businesses, because if you start creating a kind of a database, there's been situations where you have an employer looking at, might be in a big city like New York City, and say we've got several hospitals, our employees go to all these hospitals for baby deliveries, and one might have a higher C-section rate and higher episiotomy rates, and suddenly the cost is higher, the quality is less. And so can I exclude a couple of hospitals or exclude a couple of providers out of my network to give better quality and cheaper costs? Those are things that our employers will be able to shop for. We can't do that right now. We've got to create that kind of an environment. I believe in that. I think it's helpful. I think, a lot of our providers go, something else I've got to do, or it's a headache. A lot of our insurance companies don't like to disclose what they've got in private contracts with different providers because that'll expose a lot of that information. But that needs to come if you want to have people understand how much healthcare costs, and that ties in directly towards that coverage. And I think our other panelists make a good point. Having an insurance card does not guarantee healthcare. That's just the situation. We have a lot of underinsured people now, which might as well have a card and it sounds good and it's a talking point for politicians to say, hey, I got you an insurance card, but did you really get healthcare out of that? And we're having to create, a lot of our nonprofits are now treating people that are uninsured and underinsured as well. So that's a huge, huge issue that we got to say if the card actually provides you coverage or not. And I think the other big thing also in our rural communities in particular is having providers. I mean, we have to be able to attract providers to practice rural medicine. If you're from that area, you often will go back and do that. Part of that situation with it, and I discuss it everywhere I go, and it's one of the reasons why I'm in office, is liability. And we have a liability climate in this state from a business angle and also from a medical angle that really prohibits a lot of providers from coming here. It's particularly a lot of high-risk specialists, surgeons, OBGYNs, who would love to come to Kentucky, but boy, my malpractice insurance rates are about to go up 30% in this state, according to the AMA this year, and are often already double, triple what it is in a neighboring state that has protections. And so we've got to address that issue also, just to improve our workforce shortage, which is continuing to get bigger and bigger. We've got to find a way to attract providers into the state, and that'll help in terms of having, again, more providers, better quality, that often will improve our outcomes and drop our rates as well.
That's a good segue into access, because I think as we've underscored a couple different occasions already, coverage is it's a small part of the whole pie here. Access is perhaps a bigger issue in a number of different ways. And when we talk about the urban-rural divide, I think that's also where you start to see some more of these disparities really play out when it comes to the availability of healthcare services. So let's dive into that issue a little bit more now. And just as we did with that previous question, I want to start with Mark and Larry to kind of see if you guys can help us understand what exactly is going on when it comes to disparities between urban and rural residents in accessing healthcare services. What are some of the key barriers that you all see in rural areas? And I want to add to that, are there barriers that you also see in urban areas that we also need to bring into this conversation? Larry, why don't we start with you? I think you're last.
Okay, thank you, Charles. I think obviously it's already been mentioned that the number of providers that we have access to across the state is an issue. And not just in terms of primary care physician, but certainly specialists and subspecialists. We used to say that it's really not a numbers problem, it's a distribution problem. We have in our urban markets certainly a higher number of primary care physicians, specialists, and subspecialists. I'm not sure that that is a true distinction anymore, because I think we're facing shortages of primary care physicians in urban as well as rural markets, but certainly rural markets. And again, in my experience in Eastern Kentucky, it was a recruitment issue in getting folks who would be willing to come to a place where, quite frankly, their RVU is of less value because of payers and revenue opportunities, where you were inviting people to come almost as a sense of mission and vocation, and looking at the number of primary care physicians that we have in the pipeline. So all of those things come together to make, I think, a very clear distinction of access to care in terms of the number of providers we have in some of our rural markets. But back to another point that was made earlier, even if we had more providers, it's still a matter of in many of our rural markets, a difficulty of travel, major roadways, transportation, just across the board. Getting folks to the providers is a critical issue. Obviously, telemedicine is going to be very helpful, especially around telepsych and mental health. But again, the infrastructure issues related to broadband and access, as wonderful as we've been able to extend through the pandemic, necessarily so, we've learned a lot of good lessons about what telemedicine can do for us. But again, getting that to the people that need it most sometimes is an issue of infrastructure and broadband and access to use telemedicine appropriately.
So
Mark?
I'm going to weigh in on this one too, and I will echo what the other panelists have said about workforce shortage. We've talked about physician workforce. We have talked about, but I think we need a more holistic approach. It's not all about the doctors. Sorry, Senator Alvarado. You got to talk about the nurses. You got to talk about the respiratory therapists. You got to talk about the physical therapists, because it takes the whole continuum in order to do that. So I think one of the things that I would hope that we could consider is to look for a physician, a clinician workforce study for our state. Because I think we need to look at the supply that's coming out of our various colleges, College of Nursing at UK, U of L, all of our various colleges, and see what are the creative opportunities we can come together about to try to prepare that workforce. And I think some of the federal policies that drive, if the universities don't get paid to create residents, it really doesn't happen. There's caps on residency slots at both UK, U of L. We need to look at those caps, because that flipping that switch could pretty instantly change the number of professionals we have coming out. Now, not to go too far into the COVID world, I think coming out on the other side of COVID, I know, Larry, you're probably experiencing, we at UK, many of our clinical workforce is fatigued, and they're second guessing, is this the career path that I want to go on? Because they've been in combat for a year and a half now. And I think we ought to deliberately try to address that. The last point I'll make too, and I'm surprised that it hasn't come up so far, is where do people access care? In a lot of communities, people don't know how to access care, and they show up in the emergency room. And that is probably the worst place for anybody to show up with a high fever, strep throat, whatever. They don't get a continuum of care. They don't get connected to their pediatricians. So I think I like Representative Moser's support of community health workers. I think that is a very, very cost-effective approach, putting people out in the community and help with this education. deal with the healthcare literacy problem. They will listen to somebody that they grew up with, somebody that they go to church with, somebody that they see on the soccer field with their kids, and say, okay, this is where you go for primary care. So I totally support that premise.
All right, let's as we did last time, kind of circle back with public policy here. Senator Alvarado, we'll start with you this time. What can policymakers reasonably do to increase access in rural communities? And if you could also touch on some of the conversations in Frankfurt around rural hospitals, because I know that's been an ongoing conversation, and I think that might be a good one to bring in as well.
Yeah, sure. So Senator Meredith is pretty passionate. People know him. If you follow any state politics, he's the vice chair of Senate Health and Welfare and former hospital administrator, served in that capacity for, I think, 30 years, and very passionate about rural hospitals and rural healthcare. We're seeing, I think we have 14 rural hospitals now that are at risk of closing in the state. We just allocated about $20 million into a fund for hospital loans for those hospitals in particular to try to keep them afloat. And a lot of them are in trouble. And so that becomes a point. We know that if you're closer to a hospital, your outcomes are better. You have a cardiac event, you want to be within 45 minutes to be able to get that artery opened up. If you got to drive 2 hours, you're not going to make it. So it puts your outcomes are going to be worse in that regard. So having a hospital close by, is important. It's important to keep those networks afloat and open. A lot of ideas and ways of handling that. Some states have done interesting models where they'll, and I've often advocated for this as a concept for Kentucky, is to pay a lot of these hospitals, instead of doing a fee for service where they have to submit bills, is to give them their Medicaid money up front. I think Maryland has done that in a hospital approach where they pay them at the beginning and say, here's all your money for all the care for all your Medicaid patients out of your hospital. Make it work. And then, I think a hospital can take that money and budget their care more appropriately. Then they're incentivized to try to keep people out of being admitted, get them into a primary care clinic instead of coming to the ER, because it'll just dip into their costs. And so there's more motivation for that. It's had mixed results. I think it works well for rural hospitals, not so much for urban hospitals in Maryland, from what I've understood. So there's some concepts there that could be done. But I think, and again, you'd be working closer with health departments to try to use them to help you reach out to people and individualize the needs for that community, because they're slightly different in different settings. I think Mark makes some good points on GME, which is graduate medical education. We know that if you can attract a provider, if it's medical school, yeah, and I think a lot of people are investing in med school, that's all fine and dandy, but a med student will go somewhere else for residency. And wherever they do their residency, the odds are 80% that they'll practice within an 80-mile radius of where they've done their residency. I'm a case in point. I'm a California guy that came to Kentucky. I got Kentuckified at UK, fell in love with this state. And here I am doing other things I never thought I'd be doing either. So having people like myself coming in and sticking around and practicing medicine would be of some benefit. I think the ACA also had a lot of long-lasting changes in how we practice medicine, believe it or not. I'm a prime example, had a primary care clinic, independent doctor. ACA made it tough. We sold out to a hospital system and it changed all that stuff forever. And so 70+% of physicians anymore are employed. Having your doc who hangs up a shingle in a rural community like we used to see, those days are long gone anymore. And it's getting harder and harder for our providers to do that because of insurance regulations, government regulations, and that burnout that we hear about is real. Doctors used to die with their boots on. You'd practice medicine till the day you died. And I saw that here in Clark County with some fine doctors who were well into their 80s and died practicing medicine. That isn't happening anymore. I mean, a lot of guys are in their 50s, 60s with major burnout saying, how quickly can I get out of the profession because of the stressors that are coming on, the expectations, the risks. There's lots of factors to that. But really, it's not about practicing medicine anymore. It's about data entry for the purposes of insurance companies and for the purposes of government, instead of letting people lay hands on people and treat them and having that interaction. We're losing that for our providers a lot of the times. But our rural hospitals really are having a hard time. They're struggling to stay open. We've got to protect that at all costs. And I remind people, we did a study on workforce shortage in this state back in 2013. And I think Governor Steve Beshear at that time had commissioned something because he saw this problem coming down the line. And there's several recommendations in that study, taking a look at what we can do as a state. And I don't think we've implemented any of them. We've tried doing one. Again, I think medical review panels was one, and it got thrown out as unconstitutional by our Supreme Court. So we're back to square one. But there's a lot of ideas on there. And some of those are loan forgiveness for doctors coming out. I mean, it's, GME funding, all the things, some of the things we've talked about here. And we do, I think Mark makes a good point. It's not just physicians, it's nurses. I mean, you have a nursing shortage in the state desperately right now at all levels of care, hospitals, clinics, nursing homes, desperate for RNs, LPNs to come out and do that work. And we continue to put a lot of nurses out there, but they encounter the same problems. They spend 70% of their time with documentation, 30% of their time with clinical care, because we've burdened them with, things for the purposes of legal protections. And it gets old, and everybody's heard it. We know it's real. It's part of our industry anymore. If we can deburden those things from a lot of our providers, we'll bring some joy back. It's funny that the providers that are having the most fun providing healthcare anymore are direct primary care doctors, which don't take any insurance. They're doing it for cash only, probably earning half the pay, but have a smile this big on their face, and they're having a good time doing it because they don't have to deal with the insurance and all those headaches. They just get to take care of patients and do things the right way. And so that, we got to get back to that model for our providers to make them happy again. Happy provider makes happy patients. It rubs off, it goes down the system. We've got to get back to that. So our rural hospitals need it. And it's often, there's lots of factors for attracting doctors to those communities, but all those things we've talked about are some of those ramifications. We've got to get more providers there. Otherwise, we're going to be in trouble.
Representative Moser, anything else you want to add on the issue of access in particular?
Yeah, thank you, Charles. Anytime I follow Ralph, I can pretty much count on everything being covered. No, it's so true. And I think what Mark said about really getting back to that team-based system of care, where we really look at how best to serve the patient, and that community health worker, again, is a critical component of that, because we know that so many folks are struggling with food insecurity and transportation issues and housing issues and things that may not seem directly related to their health care, but they absolutely are. And so, that's just one piece of this. I think we talked a lot about keeping and attracting physicians to Kentucky, and you're all very right about this is a team-based approach, so we need to pay attention to nurses and all of our team. They're not even ancillary support, which is how they used to be looked at. Everyone is a critical member of the team, and we really need to think about that when we're putting policies in place. And Ralph's right about the regulatory burden, the burnout. My husband is a pulmonologist and critical care physician, and spent the last year on the front lines of taking care of COVID patients. And burnout is real. He has maybe one day off a month. It's intense. And when you have to come home after seeing 30 or 40 patients a day and chart for 4 hours, which is literally what his evenings and our evenings are comprised of, it's really frustrating. So, there are plenty of issues that we could work on a federal level. Those are those GME caps. I did a lot of work outside of the legislature before being elected with the AMA Alliance, and working on things like lifting the GME cap on a federal level. That we absolutely need to pay attention to work-life balance. Any physicians on the participant list, right now knows exactly what I'm talking about. There are all sorts of policies that we could talk about. Again, getting back to how do we attract providers to a rural healthcare system, rural area. It's going to be resources, it's going to be schools, it's going to be all of the things that make an area attractive to relocating your family. So there are things that we can do to improve access to care, but if you want to get providers into certain areas, you're going to have to look at things like tax credits, perhaps, to incentivize folks, or tuition reimbursement, things like that, to really get folks to stay in Kentucky.
Yeah, I'm glad that glad and both not glad that the workforce issue has come up on several occasions already in this conversation, because when I was doing research to prepare for this panel discussion, that was a very common issue that came up repeatedly. And obviously other states are going to be exploring similar strategies because other states are in the same predicament in terms of their healthcare workforce. And then of course, at large, we're dealing with a workforce issue throughout the state, throughout the nation, which has been a major concern for the Kentucky Chamber. I want to shift over to technology for a few minutes. Obviously, there's been major technological change in the healthcare industry over the past few decades that seems to be accelerating, some of which perhaps has been necessitated by COVID-19. But what I want to just sort of open up to the panel as a whole is how do you see technology changing the delivery of healthcare in both urban areas and rural areas? And I'd be particularly interested to know if you all see any divergent trends when it comes to technology. So is there stuff happening in urban healthcare environments when it comes to technology that aren't happening in rural settings and vice versa? So I'll just kind of open that up to the panel as a whole and see if there's any comments.
I think we've seen, I think initially with telehealth, with COVID, obviously we saw a big surge. And again, we got this bill passed back in 2018, had a lot of resistance, and Kim knows who I'm talking about, from certain players who thought it's going to increase the cost and it's not going to be good, people will abuse it and all these sorts of things. We got the bill done, and it made Kentucky one of the more attractive telemedicine states in the country with that bill. And then when COVID hit, all those people who gave me resistance said, thank goodness we got that done, because if we didn't have that, we couldn't have delivered a lot of care. And now we've expanded it. I think Representative Mosier did it, and Representative Frazier worked on a bill to expand that telehealth bill to really provide a lot more coverage and other aspects of it. So we're excited for that. That's kind of a stop measure gap for us really as a state to, we're short in a lot of providers. I mean, there's a lot of provider shortages. Just for example, in rural areas, I do a lot of long-term care, don't have enough neurologists for our dementia patients and some of those things. There's some deserts really in parts of the state with a lack of providers for those kinds of things. Suddenly telemedicine allows for that person to lay eyes on that individual, provide us a diagnosis and some treatment patterns. The same thing with mental health coverage, psychiatry services that I tell people this statistic all the time. We have about 1 million children in the state of Kentucky. I think the last time I checked, we had 59 child psychiatrists for the whole state. Half of those are cash only, don't take any insurance. So you can imagine the shortage and the need and the increasing need for mental health. We just don't have it. So we've allowed other, as long as you're licensed in Kentucky, you could be anywhere in the country and provide that care. That's really it's come a long way in terms of doing that. Now we've seen those numbers spike with COVID. I think they're starting to come back down because doctors are just naturally, we want to lay hands on people. I can't do an abdominal exam through a computer screen, and the liability is the same for that provider. So you have to see those folks live. I think we prefer it. Physical exam, that's part of your natural thing. So we're going to get back to that, but I think we're starting to see an expansion of it. I think we're looking at things like digital therapeutics just for substance use disorder, where someone can use their phone to get some of their mental health treatment that's been FDA approved. And frankly, we have a generation coming up that is often more honest with their cell phone than they will be with a provider that they're talking to face to face. And so they can get more out of those treatments as well. So I think it's here to stay. We have to use that to our advantage. We have to be careful that we don't abuse that there are some providers who might, use that instead of seeing people live. I think we have to be careful with that, but it's become part of what this next generation is going to be using, and it can provide, again, those services. And for areas where you can't get access, again, if you have a snow day, it used to be you shut your office down and you couldn't see patients. As long as you have a connection for broadband, you'll be able to say, hey, I can see, Mrs. Smith from home and follow up a lot of her issues and continue her prescriptions and continue to address a lot of those problems. So it's a real useful tool. I think we're going to see it come back down a little bit, but there's going to be a lot of people who, again, will rely on that just for simple needs. And again, if I've encouraged even our hospitals to use that instead of relying on people coming to the ER for something simple, have a kiosk in your ER waiting area where the wait might be 3 hours to be seen for what might be a cold. Say, hey, why don't you, if you want to wait 3 hours, or you can go over here to a computer screen, dial in, see a provider that's covered by your insurance and do it for $50 instead of charging $500 for that ER visit. It's going to help contain the cost of care as well. So lots of benefits, but we're going to be working towards that.
I appreciate those things that you just mentioned, Senator, because it's not just a matter of, it is an issue of access and where telemedicine can help us with access, but it's also, I think, a way for us to address some of the cost issues. Charles, you mentioned how fast technology is changing and is growing, and we all want the next best technology or the best technology. The reality is we don't have to afford and increase healthcare costs by putting that technology in every venue, in every place. There, as much as I believe we've got to get access out to every corner of the state, reality is there are some services that belong in larger centers where they treat more patients, improve quality, have teams, dedicated teams to do that. And I believe that there are many ways that telehealth can help us connect people to the right place, to the right resource, and get the care they need without duplicating services across the entire state. And so there are some centers of excellence. I know that that Mark and his team are doing a lot of that work as well, to be able to get access to specialists and subspecialists out in those other markets. And I think that's a way for us to also continue to hold down some of increasing healthcare cost.
So I totally agree with the senator and with Larry. To some extent, the COVID and the telehealth that came as a result of that and the state legislation has kind of bridged that gap between the urban and the rural, and has opened up that connectivity, pardon the pun, between the clinician community and the practitioner. So there is a policy piece to this that CMS was much more flexible on Medicaid and Medicare reimbursement for telehealth. I'm hoping they don't close that door again, because I agree there has to be still some face-to-face connectivity, but for follow-up care, for diabetic check-ins subsequent to their face-to-face visit, it's very cost-effective. It's very quick, simple. It gets around that transportation barrier that I talked about at the beginning, but we got to have the broadband. But it's a good addition that I hope we've all got our fingers crossed that CMS does not come back through and reinstate a lot of the barriers that were in place on telehealth that were in place prior to COVID.
And I should just chime in here and let folks know, if you don't already, that the legislature did appropriate $300 million for broadband access. So, for those areas in the rural parts of our state who really struggled with broadband access, hopefully the last mile will be strengthened, and access to care will be strengthened. Using that technology. And something that we haven't talked about, we talked about the flexibility of CMS. I think Mark acknowledged that we need a little more flexibility through Medicaid, really. And there is a return on investment, we know, when we provide care in school-based health care centers, for example. So that's a state plan amendment that was came down or was applied for in the last administration. That is being continued. And that's a point of care that really hasn't been addressed. And those are families and children who will be identified in school. If we put a nurse in every school, we expand that referral base. Again, we can use telehealth in those instances. And so we increase the connectivity of individuals in a really convenient way, a really cost-effective way, to identify kids who are truly at risk, or maybe a child has an earache and the parent can't leave work to come and get the kid out of school. And, so small problems can be addressed immediately. Larger issues can be addressed on a referral basis, those sorts of things. The cabinet has also applied for an 1115 waiver to allow for treatment during incarceration. So those sorts of things we know will improve the continuum of care for individuals who are at risk for a multitude of issues, substance use disorders, and mental health issues. We also passed a bill to increase or improve mental health parity. House Bill 50 this past session will align state mental health parity laws with the federal mental health parity laws, and basically require coverage for mental health issues at the same rate as any other healthcare issue. So there are some positive notes on policy that are happening. We're really paying attention to and taking kind of a higher level look at our healthcare system. So I'm really enjoying this conversation. It's all of our passions. So.
Representative Moser, I'm glad you brought up mental health and substance use. Both of those were topics I wanted to get to. Unfortunately, we're running out of time. And so there's numerous other topics I was hoping we could address, but we have about 4 minutes left. So what I'm going to do here to close out this 4 minutes is I want to turn again to each of our panelists. We started this conversation out by talking through some of the disparities between urban and rural healthcare. I want to go now to more shared challenges and see if the panelists have particular shared challenges that they might point to, that they see as sort of commonalities. They might not have the same solutions, but we might have similar problems between urban and rural communities when it comes to healthcare. So I'm going to open that up to the group as a whole and see what you all think in terms of shared challenges that our audience might need to be aware of.
So I'll jump in with one shared challenge. I think everybody on this panel will probably agree with this, that coming out of COVID, there are people who were afraid to seek healthcare during the lockdown periods. People did not get cancer screenings. People did not get diabetes checks. People didn't get dental checks, And I know, Larry, you all are probably seeing it. We're seeing it where patients are presenting with cancer that is further progressed. When had we caught it in March of 2020, it could have been much more easily addressed. So I'm call that the pandemic, the epidemic after the pandemic. I think there is a challenge of how do we deal with this with a reduced workforce. So I think it's a real challenge for all of us.
I agree with Mark wholeheartedly. We're seeing that experientially right now. And I think it also has shown a spotlight on the impact of disparities, all the disparities we've already talked about as well, because as we're seeing this now with people who did not seek care that they should have or could have during the pandemic, it is also highlighted that was already happening in many of our rural markets through, again, back to the access issues, as well as in some of our urban markets, where people are being diagnosed with much later stages of cancer, where we know that with lung cancers don't present symptomatically until probably it's very late stage. And so early lung cancer screenings, colon screenings, all those things we know can help with outcomes. We're seeing actually exacerbated problematically in both rural and urban markets because of the pandemic. But they already existed, and we already were needing to address those things more actively.
And I'll jump in because I think what I need to say or want to say dovetails with what Larry was just talking about. And it's really, in my opinion, one of the key factors is health literacy and helping individuals really understand when they need to seek help. Who do they go see? I mean, we as healthcare professionals kind of take it for granted that everyone knows and everyone doesn't know. And so I think that if we can reach the population at an earlier level or earlier time, to your point, Larry, I think that we could, and Mark, I think you talked about this too, during COVID, getting people the care that they need in a timely fashion and not abusing our emergency departments as primary care. So, if we can really increase the health literacy, again, I'll come back to those community health workers as the connector and, really kind of tying all of this together.
Two quick things, Charles. You mentioned already, substance use disorder crosses entire state, rural, urban, rich, poor, black, white, church going, non-church going. It doesn't matter who you are. That's across the board. I know Chairwoman Mosier has a tremendous passion for this and a lot of knowledge in this space as well. We rely on her a lot for a lot of the information, what we need to do as a state, but that's something we have to continue across the board to continue to work on, again, reduce barriers, destigmatize this, get people to help, get them into the workforce, get them back into society, and to help those folks. So that's one of the issues. The second thing I know I'll mention is vaccinations. We talk about vaccines for COVID. Our vaccination rates for pediatric vaccines are dropping in this state. And although I don't support forcing people into it, and there's some people on this call that are watching that I know have advocated and written articles on that, thinking that we should mandate and force people to do it, I don't think we should do that. But we're losing the argument. And as doctors and as medical professionals, we need to do a better job of letting people know why vaccines are important, the diseases they prevent. And we're starting to see outbreaks. And I'm telling you, if we don't do something now and start winning that argument publicly, we're going to start seeing that outbreak happen across the state. And it's going to get into rural areas where we haven't seen measles outbreaks in a while. We haven't seen mumps, rubella, diphtheria, tetanus, polio, things that killed kids, adults across the board in droves. People were coming out like crazy to get those vaccines. You have a generation coming up now that's taking those things for granted. And when we start to see those where doctors haven't seen them in the past, there's going to be a delay in diagnosis and getting those people treated. We've got to get back to winning that argument again. One other thing I think we can all agree on, and I want, as we're ending this conversation, a little birdie told me today that it is Chairwoman Mosier's birthday. So I think we can all agree we want to wish her a happy birthday today as well, spending her time with us on her birthday.
Thank you.
Sure.
Thank you. That's very nice. Thanks. I kind of forgot. I was so wrapped up in the conversation. Thank you.
Absolutely. Yeah. Happy birthday. And thank you, Representative Moser, for taking time out of your day for that. Well, I hate to see this conversation come to a close. I know I learned a lot, and I have quite a bit that I'm going to think about, I think, over the next little while as this conversation ends. So again, I want to thank all of our panelists for taking time out of your day, lending your expertise and giving us your time. We really appreciate that. I want to thank our partners at the Martin School of Public Policy and Administration for partnering with the Kentucky Chamber of Commerce for this conversation. And I think we all agree, having honest and thoughtful conversations about Kentucky's urban-rural divide is a critical part of how we're going to ultimately bridge those divides. And so with that in mind, this is the first webinar in a series of webinars that we are going to be doing on the urban-rural divide. You will have more scheduled for July and August on issues such as education and economic development. So please be on the lookout for more announcements regarding those webinars. And with that, thank you again to our panelists, and thank you again to our virtual audience members. And I hope everyone has a great rest of your afternoon.